Welcome to Mercy Medical Center's live webinar. Today we'll be discussing updates in breast health. Joining us is Katie Feldman, certified breast care nurse at Mercy's Women's Center. After a discussion, Katie will take questions from our audience. To submit your questions anytime during the discussion, go to the window in the upper right-hand corner of your screen and type in your question. If you don't see the screen, click on the orange box with the white arrow. Your questions will be anonymous, completely confidential. So welcome to the webinar, Katie. Let's get started.
Thank you, and thank you all for joining us today. I'd like to start with just some facts about breast cancer. Many of you may know breast cancer is the most common cancer in women in the United States, other than minor skin cancer. However, it's the second leading cause of cancer death in women, and that's followed by lung cancer. Last year, there were approximately 207,090 women diagnosed with an invasive breast cancer, and 54,010 women diagnosed with an in situ cancer. And in situ means still at the site of the original cancer. The cells have not broken through the wall of the duct or the lobule, so it's actually the earliest form of breast cancer. And last year there were 39,840 deaths from breast cancer. Certainly it's one cancer that we have the most written about. It's the most feared by many women, most media coverage, and certainly is the most public awareness of any disease. It seems like very frequently we have celebrities that have been diagnosed. Recently, Robin Roberts, Sheryl Crow, Christina Applegate have spoken out about their experiences. Some other interesting things that while the incidence rate is increasing slightly each year, the death rates are going down. Now we say the 5-year survival rate for localized or early stage breast cancer has increased to 99% from at about 80% in the 1950s. So that's tremendous progress. And currently there are about 2.5 million breast cancer survivors in the United States. Many times when you hear the word breast cancer, you think of it as just one disease. But actually, it is not just one disease. There are many different types of breast cancer. And that can help explain why, your Aunt Sally had a different treatment than, your neighbor Susie, because they probably had different diseases. Invasive ductal carcinoma makes up the vast majority of breast cancers. It accounts for about 65 to 80% of all breast cancer diagnoses. The next common type is invasive lobular that accounts for 10 to 15% of breast cancer diagnoses. Then we have a variety of other different types that occur at a very low percentage, and these are things like medullary, tubular, colloid, papillary, inflammatory, and then Paget's disease. I want to talk a little bit about risk factors for breast cancer. Certainly family history plays a role. If your mother, sister, or a daughter has been diagnosed with breast cancer, you have a greater increased risk of having it. If you have a mutation in the genes, the BRCA1 or the BRCA2 gene, your lifetime risk of breast cancer is significant. Having a long menstrual history is another risk factor for breast cancer. And by that I mean if you started your menstrual period before age 12 or went through menopause after age 55. Being overweight is a risk. Age is a risk, as is drinking alcohol, not having any children, not giving birth to any children, or having your first child after age 30 is a risk. Other risks are greater than 10 years of oral contraceptive use or postmenopausal hormone replacement therapy. And that's a little controversial. The research is not 100% certain about that. Other things that definitely can increase your risk are if you've had a biopsy where the pathology results showed atypical hyperplasia, or if you've been diagnosed with lobular carcinoma in situ. And one final risk factor, having dense breasts. And about 40% of all women, especially under 40, do have dense breasts. And actually that can increase your risk 4 to 6-fold of developing breast cancer and of having a false negative mammogram. That being said, about 70 to 75% of women diagnosed with breast cancer have no significant risk factors. Our most significant risk factors are ones that aren't modifiable. Being a woman and getting older are the key players. And since we know there are many risk factors that we can't modify, we can't control our menstrual history, we can't control our family history or the fact that we're female or aging, we have to look at other ways that maybe we can reduce our risk. That really falls into 3 categories: lifestyle modification, including things like nutrition and exercise. There's some medications that can reduce risk. Tamoxifen and raloxifene are 2 medications. And surgery is a risk reduction strategy, usually reserved for those women at extremely high risk, possibly with a known genetic mutation. So prophylactic mastectomy or an oophorectomy means removal of your ovaries. Nutrition plays a very important role in health overall, and certainly in reducing our risk of breast cancer. Eating a diet that's more plant-based is a healthy option, and that means eating more fruits and vegetables, whole grains, legumes or beans, nuts and seeds, rather than relying on meat as our main intake. Some examples of really nutrition-rich foods are kale, cabbage, broccoli, blueberries, raspberries, tomatoes, flaxseed, wheat bran, just little nutrition powerhouses. Other nutritional points to keep in mind are avoiding saturated fats, look for monounsaturated or polyunsaturated, and avoiding trans fats. And limiting or avoiding alcohol. They say for a woman, she should not have more than 2 drinks a day. And the alcohol comes into play because an increased intake of alcohol can boost your estrogen levels, and more circulating estrogen can raise your risk overall. And maintain a healthy weight. Very important also, so we don't have extra circulating estrogen. The research on supplements is not very clear or very helpful to us at this point in time. There's some research that shows taking a fish oil supplement could reduce your risk of invasive ductal cancer. Some research is positive, some is negative. We think fish oil is beneficial for cholesterol, so some people are taking it for that. The exact dose is not well defined, depends on your other health problems and other medications. But if you're taking it to reduce your cholesterol, you may get a side benefit for reducing your risk of breast cancer. Research hasn't shown any proven benefit of evening primrose oil, extra vitamin D, and that's just for breast cancer. Vitamin D, very good for helping prevent osteoporosis, or soy products. And actually women who've been diagnosed with breast cancer are generally advised to avoid intakes of large amounts of soy. Physical activity, again, like nutrition, plays a very important role in our overall health and can play a role in reducing our risk of breast cancer. We found that women who are physically active have a reduced risk of breast cancer. Women who are diagnosed with breast cancer and adopt a physically active lifestyle have reduced recurrence rates. The Women's Health Initiative, which is a very large multi-center study, showed a 20% reduction in breast cancer risk for postmenopausal women who walked 30 minutes daily. So not even an unreasonable amount of exercise. The American Cancer Society recommends 45 to 60 minutes of moderate aerobic exercise most days to decrease your risk. So we've talked a little bit about risk reduction, and that's very important. But the next key piece is, since there's some risk factors we can't control, early detection is our best protection. There's been some controversy in the last few years about when to get a mammogram or who should get a mammogram, but the current guidelines endorsed by the American Cancer Society, the American College of Radiology, recommend mammograms yearly starting at age 40. And a clinical breast exam by a healthcare provider yearly starting at age 40, and every 3 years for younger women, ages 20 to 39. Breast self-exam is recommended monthly starting at age 20. We have less of an emphasis on that now, so if you practice breast self-exam, that's great and keep it up. If you don't feel guilty about it. One of our other options for early detection is an MRI, a magnetic resonance imaging exam. And that can be very useful for screening women with dense breasts or those who are at very high risk because of strong family history or a genetic mutation. One of the newest modalities that can help us in our detection of breast cancer, which personally I'm very excited about, is MBI, or molecular breast imaging. And it is a very useful tool for screening women with dense breasts. Could be useful for monitoring women with a known breast cancer and their response to chemotherapy. And it may be an alternative to an MRI and or an ultrasound in the workup of patients that have questionable or suspicious findings on their mammogram. It's a problem-solving tool for us, not ready for just general screening of everyone in the public. This test has a high degree of sensitivity. It's about 90% sensitive. And when I say sensitivity, that means the ability of the test to correctly identify those with the disease. So if the test is positive, then it is a true positive. You truly have the disease. This MBI is also very specific. It has a high degree of specificity, which means the ability to correctly identify those without the disease. So if your MBI exam is negative, it is most certainly true that you do not have breast cancer. So a very good test, and it's also less expensive than an MRI exam. The test itself is unique or interesting in that it involves an injection of a radioactive tracer and then breast compression, though not to the degree of a mammogram. The theory behind it is that cancerous tissue takes up the radioactive tracer and so it lights up on the imaging exam. And this technology is coming to Mercy very soon. Probably, actually the equipment is due this week, and we'll begin testing patients and offering that test. So if you know you have dense breasts or genetic mutation, check with your doctor about that, the utility of that for you. I did want to touch on just a few things that are non-cancerous breast changes. Many times we find a problem and immediately assume, oh, it's breast cancer. But there are many things that are not cancer. Fibrocystic breast condition is one. A few years ago we called it fibrocystic disease, and it's not a disease process, so thankfully we've gotten away from that. And that is really just the people who have lumpy, bumpy breasts. You form some small cysts, you have some fibrotic areas, not cancerous. The formation of cysts. Cysts are just fluid-filled sacs that can form in response to hormonal changes that occur throughout the menstrual cycle. Those often are the lumps that come up quite suddenly and are quite painful. Certainly they need to be checked out, but most oftentimes they're simple cysts that resolve over time. Fibroadenomas are a solid tumor that occurs in the breast, and again, that's not cancerous. And neither are intraductal papillomas. They're little growths that occur within the ducts. Blocked milk ducts sometimes can form lumps or cause problem, and they can be resolved in other ways. Discharge from the breast. If it's milky or greenish, that's not typically a concerning type. Milky discharge sometimes can be related to hormonal issues. Greenish discharge is often related to chronic cysts. And injury can cause a lump in the breast. Just like if you bump another part of your body and you get a large bruise, you can get a bruise inside the breast, a hematoma that will resolve also over time. I wanted to talk a little bit about some of the updates in our treatment options for women who have been diagnosed with breast cancer. Typically, there are 4 different treatment modalities, and some women will have all 4. Some women may have only 1. Some women, 1, 2, and 3. So it varies depending on your unique situation. Typically, surgery is the first line of treatment, if necessary, followed by chemotherapy, followed by radiation, and then hormone therapy. There's a subset of people, women that do have chemotherapy first, followed by surgery. But again, it's very specific to your unique situation. As far as surgical updates, medically we've known for a while that lumpectomy plus radiation is equivalent treatment for early stage breast cancer to a mastectomy. And I think, as I said, medically we've known that. It hasn't been as well known in the general public, but just being diagnosed with breast cancer does not automatically mean you'll lose your breast. Lumpectomy and radiation is a very viable option for many women. Big progress in the treatment of breast cancer. We're learning now that axillary dissection may not be necessary for women with positive sentinel nodes. And what that means is right now, women who's diagnosed with an invasive cancer will have 1 or 2 or maybe 3 lymph nodes examined at the time of surgery to see if there's any cancer in those lymph nodes. It helps us gauge if the cancer has spread outside the breast. At this time, if those lymph nodes were positive, the surgeon would do a complete axillary dissection. They would make a little bit bigger incision and take out all the lymph nodes that they could find for further testing by the pathologist. Now our research indicates that might not be necessary, and that would be would reduce the risk of certain problems for women down the road, whether that's pain or web cording or lymphedema. So that's actually very exciting news for women with breast cancer. And still under investigation, but really exciting, they're working on some minimally invasive surgical techniques to treat breast cancer. And that includes things like using a laser to destroy the tissue, or cryoablation, which is using very extreme cold to destroy the tissue, and radiofrequency ablation using radio waves to destroy the tumor. So rather than an incision and having tissue taken out, it would be a small probe inserted right to the tumor area. So still investigational, but exciting for what the future might hold. As far as chemotherapy, chemotherapy is given to certain women to reduce their chance of recurrence and to reduce their chance of dying from their breast cancer. It's very important to have an individualized risk-benefit ratio analysis to learn exactly how much you will benefit from chemotherapy and versus the risks that you would undertake going through that. One of the ways that we have had just in the last couple of years to help us determine that risk-benefit ratio is this test called Oncotype DX. And it's a test where they take the some of the tumor, some of the tissue, and analyze it for, I think, 26 different genetic components, and through a very complicated mathematical formula that I don't understand, they can come up with a number, your recurrence score. And it's very useful in making decisions about chemotherapy, because if your recurrence score is high, above a certain number, your chance of benefiting for chemotherapy greatly outweighs the risks taken to you. If your number is low, then typically the benefit that you would derive from chemotherapy doesn't outweigh the risk to your health. And so it can really help guide your decision making in conjunction with your doctor. And of course, there's lots of research going on now to focus on the biology of your particular tumor so that we can tailor make your chemotherapy regime. Tumor markers that we look at right now, we look at estrogen and progesterone receptors, and that if those are positive, that helps us. We know that certain medications will work for you. If they're negative, we know that certain medications won't be effective, and we need to look to another line of therapy. One of the other markers that we measure now is this HER2/neu, and just this summer there was a new test approved to measure that, to give us more accurate information. And we know that if your tumor is HER2/neu positive, we have a certain chemotherapy drug, a drug called Herceptin, that we can give you that can be very effective for you. It doesn't do anything for someone who's HER2 negative. There are many biomarkers that we're studying now to see if they can give us even more information about how your tumor will behave and how we can treat it the most effectively. And they're looking at things like cancer stem cells, circulating tumor cells, the microtubule, associated protein tau, the beta-3 tubulin, topoisomerase 2, some of these I just can't even pronounce, and thymidine phosphorylase. So exciting things on the horizon too with regard to helping us understand the tumor. Neoadjuvant chemo is an option that can be offered to some women, and neoadjuvant means first. It's the first treatment that we give. So that is chemotherapy given prior to surgery. Usually offered for women that either we know the cancer has already spread beyond the breast, or based on size and clinical features, we're concerned that it has spread beyond the breast, because chemotherapy is systemic, so it'll attack those cancer cells throughout the body. Some of the benefits are it might allow a woman to have breast-conserving surgery, which means maybe that the chemotherapy would shrink the tumor so that she could have a lumpectomy instead of a mastectomy. And by measuring the tumor size and the response to chemotherapy, we can see, is it working? And change treatment or refine the prognosis a little bit. Radiation therapy, as I said, is a partner to a lumpectomy, and it's also sometimes given if a woman has had a mastectomy and meets certain criteria. But most women with a lumpectomy need radiation therapy. The goal of that is to eliminate any microscopic disease in the breast. Our gold standard that we have offered women for many, many, many years is 6 to 6.5 weeks of what's known as external beam therapy. So it's a radiation treatment to the entire breast, and that's Monday through Friday for 6 to 6.5 weeks. What we are offering some women now, postmenopausal women who meet some other criteria, is what's called accelerated partial breast irradiation. In this option, treatment time is reduced to 5 days, so it can be a convenience issue for some women. Some women maybe who lived a distance from a radiation center, it gives them the option to have a lumpectomy. In the past, maybe they just said, I'll have a mastectomy because it's too inconvenient for me to go somewhere for radiation. So it just expands our options. What it involves is actually the insertion of a little balloon catheter right into the breast where the lumpectomy was taken, and the radiation passes through that catheter just to radiate the tissue surrounding the original tumor site. And so women have treatment twice a day for 5 days. Very positive results thus far. So these are the main treatment options that we've talked about. I wanted to talk a little bit about Mercy's commitment to women in our community with regards to breast health. We have a definite focus on early detection. We have mammography services at the hospital, and we have a mobile mammography unit that takes accredited services out to women in businesses in our community, as well as many small towns in eastern Iowa. We also offer walk-in appointments at the hospital and on the mobile mammography unit for your convenience. So if you have an order from your doctor, you've had your physical and you're off work the rest of the day or until noon, come on over and you can have your mammogram. We have a strong focus on care for the and the underinsured. For 21 years, we've had the Especially for You Fund. The race that we have in the fall, the proceeds go into this fund, and it pays for breast care services for women in our 7-county area who otherwise would not be able to afford them. And those breast care services include things like a visit to your health care provider for a breast exam and to obtain an order for a mammogram and an ultrasound, and it will pay for a biopsy if that's what's necessary for a woman. We also partner with our Lynn County Health Department and the Care for Yourself program that can pay for services for a woman who is diagnosed with breast cancer, needs to go beyond the biopsy for a surgical referral, etc. So we work very closely with our programs and services to make sure that no one goes without care who needs it. And we have a very strong focus on coordinated, comprehensive cancer care to the effect that we're building a brand new cancer center, the Hall Perrine Cancer Center, which should be opening early in 2012. As I mentioned, the Especially for You Fund is available for women in our service area, and this year our race was on Sunday, October 2nd. I hope many of you were able to participate in that big sea of purple on that lovely Sunday morning. This year we had 15,792 participants, men and women, children, so that's a wonderful sight to behold. We had 383 teams registered, and those were groups of 15 or more people, oftentimes, personalized or, dedicated in memory or in honor of someone, and it's always fun to see the different teams and see what they do with their t-shirts. And probably the best news, we raised over $375,000 for the fund, so we can pay for lots of breast care services. So if you need breast care services, or you have a friend or family member, please let them know about the Especially for You Fund, and we would like to help them. And if you would like more information, you can contact me at Mercy Women's Center at 319-398-6602, or via email at kfeldman@mercycare.org.
Well, thank you, Katie. That was excellent information. To remind our audience, your questions can be submitted from the box in the upper right-hand corner of the screen. And again, if you don't see the box, click on the little orange box with the white arrow, and the full screen will be displayed. Okay, first question we have, Katie, the listener writes, I don't have the time or energy to walk 30 to 45 minutes. Can I break it down to 10, 15-minute walks and still get the benefits of reducing the risk of breast cancer?
Oh, yeah, great question. And we do think you get the benefit if you break it down. So maybe you can, if you work outside the home, you can park farther away so that you get your 10-minute walk going into the building and 10-minute walk going back to your car at the end of the day. And maybe you could do 10 minutes on your lunch or a break time, or take the stairs. So yes, it is possible to break that up and still get some benefit. So just find those simple ways, or when you're going to the grocery store, park further away to walk in. When you're dropping your kids off at school, park farther away and walk in. Just look for those little ways to add distance to your walk.
Another question we have is molecular breast imaging painful, and are there any side effects we should be aware
of? I would say there's a little discomfort from the injection of the radioactive tracer. They'll either do that via a little butterfly IV in your hand, or an injection in the crook of your arm, like where they would draw blood. But pretty minor, I would say. The other people have asked us about the compression, and I haven't experienced it yet. After we get the equipment, maybe I'll be able to give you a better idea. But the manufacturers tell us it's 1/4 the compression force from a mammogram. So they're really just trying to hold your breast in place. And not compress it to the very thinnest possible, like in the mammogram. So I don't anticipate a lot of discomfort with it. Side effects, not that I'm aware of right now.
Very good. Will insurance cover an MBI?
At this point in time, only Medicare covers an MBI. So initially it will be all self-pay. I think more insurance companies will begin to pay for it. They are starting to in other states. And part of that is because it's less expensive than an MRI, which is a couple $1,000s. And so for many women, even paying for the exam might still be less than your copay for an MRI. But it's something, check with your own carrier. And I think the more women that ask about it, the more awareness there'll be, and that'll speed the coverage up for that exam.
Katie, another question, is breast cancer in a man treated the same as for a woman?
Oh, that's a good question. And now that you say that, I realize I didn't talk about that at all. Breast cancer does occur in men. It's really about 1 or 2% of the cases, of the diagnoses each year. And so we do see that on occasion at Mercy. And yes, it typically is treated similarly to women. Men have a mastectomy. There's no real option or benefit to doing a lumpectomy. So they may have a mastectomy and may be treated with similar chemotherapy drugs if that's warranted.
Going back to the EFY, what number do I call if I need the EFY funds?
You can call the General Women's Center number at 319-398-6690, and we can send you out an application form or answer your question or direct you to anything further.
Going back to the nutrition section, we have a caller asking, how much fish oil should I take to reduce the risk?
If you'd like to try fish oil to reduce the risk, do talk to your healthcare provider first. You know, in looking up some information about that, the dose varied. If you also have heart disease, or if you also have diabetes, or if you're taking certain medications, so it's best, you need an individualized answer to that question depending on your own health situation. So do ask your healthcare provider first what's the best correct dose for you.
I believe we have covered all the questions submitted to us, but if you have additional questions, please call Katie at 319-398-6602, the number on your screen, or email her. If you call, you may get a voice message, but Katie will definitely return your call. Now, a tape of this program will be available at www.mercycare.org/live. And you can always check this website for information about future webinars and listen to past webinars. Our next webinar, Understanding Palliative Care with Joni Henderson and Christine Harlander from the Mercy's Palliative Care, will be Thursday, November 10th at noon. And again, they will take your questions live after their presentation. Let's see, we have another question that's come in. Okay, Katie, another question. What about the nurse navigators for breast cancer patients? Can you share any information about this?
Oh, that's an excellent question, and I'm so glad you asked that, because we have the most wonderful nurse navigators at Mercy, and it's a service available at no charge to cancer patients, and they're nurses, so they're knowledgeable healthcare professionals, and they are there to guide you through your cancer experience. They're there to be a resource to you, to answer questions, to clarify things that have been discussed with your treatment plan, to help you obtain other resources that you might need. If you're having chemotherapy and you need to know, where can I get a wig that looks nice on me, or where can I get some scarves, and how can I learn to tie scarves? Your nurse navigator can help you. If you're driving for radiation every day and paying for gas is a problem, your nurse navigator can help you with that. Any problem, if you're having trouble coping with this diagnosis and the change in body image, the change in family relationships, your nurse navigator can provide emotional support, information if you need counseling. They can refer you on, so they can link you with other service providers, other resources in the community, and they're just one phone call away or one visit away, and it's a wonderful service.
All right, thank you, Katie. Again, I believe we've had our question answered, but again, do not hesitate to call Katie at 319-398-6602 if you think of a question after we sign off here. So thank you all for joining us.